Thank you. Thanks again for the invitation to speak here in Brazil. This is going to be a talk that is not going to have any hardware, which is something unusual when you think of orthopedic trauma. But I think this is an important topic that we need to address, and hopefully you'll understand after the next 15 minutes. I don't have any conflicts with anything that I'm going to present today. We'll cover the definition of osteoporosis. We're going to talk a little bit about the prevalence, both in the United States and Brazil, how it's a huge health problem, look at some cost numbers, and then briefly touch a little bit on what I think we all need to do as orthopedic surgeons. So osteoporosis in a nutshell is low bone mass. So it's normal bone, it's just not enough of it. And we certainly see that as our patients age. This is the typical score that we use. We used to use a Z-score, now we use a T-score. A T-score of minus 2.5 or greater tells you have osteoporosis. This is a tool called the FRAX, so I don't know how many people are familiar with the fracture risk assessment tool. We use it routinely on all our patients over 40. They are country specific, and starting about 2014, they actually had very good data for Brazil, and so you can use this tool if you're not using it now, specifically for your patient population. Prevalence in the U.S. is quite dramatic. 44 million Americans have osteoporosis or low bone mass. The majority are women, and every 1 out of 2 women and 1 out of 4 men over 50 are going to have some sort of osteoporotic fracture in their lifetime, which is a staggering number when you think about that. When we look at Brazil, I don't have quite the same data, but a third of the women over 50 have osteoporosis, and the fracture risk is still about the same. 1 in 2 women and 1 in 4 men over 50 are going to end up having fractures. When we look at how many fractures we see, this number in the U.S. now is almost 2 million. A huge number of hip fractures, over 300,000, a lot of vertebral fractures. And what was really surprising to me was when I looked at some of those numbers for Brazil. So again, about 125,000 hip fractures annually, but more amazingly was the number that was estimated for vertebral fractures. And for whatever reason, there seems to be a higher predilection in Brazil, but they said almost 3 million vertebral fractures are present in Brazil. And when we look at aging, aging is really the biggest problem we have. So incidence for all of the osteoporotic fractures, when we think of our patients in the United States, have curves that look like you see there. And as they get older, of course, their risk for fracture increases fairly dramatically, especially the spine and hip. And this is what it looked like in 2006, where the majority of our population was. This is what it's going to look like in 2030. The majority of our population is going to be much older, and they're going to be at much higher risk for having these fractures. The same rates apply in Brazil, very much paralleling the increasing age. So roughly 22% of your population is over 50 right now, 4% is over 70. But by 2020, so not very far away, we're going to see that shift, just like we saw in the United States. 37% are going to be over 50 and 17% over 70. And hip fractures are estimated to increase in Brazil by 16% to 2020 and 32% by 2050. So fairly dramatic numbers, again, very similar, having to recognize this is a huge problem. This is always a way I sort of talk about this problem in the United States, and if we look at heart attacks, strokes, and breast cancer, all of which gets a lot of publicity, has a lot of money put forward to it, collectively all 3 of those don't come close to the problem that osteoporosis causes us in the United States. And our Surgeon General in 2004 really highlighted this as a problem nationally and said we need to do something with nutrition, physical activity. We really need to understand how much of a problem this is. We need to do better with diagnosing and treating in our everyday lives. And we've made very little change since then. In Brazil, one of the few Latin American countries that actually recognized this as a problem and declared it a national health priority in 2014. And your Professor Cristiano Zerbini, a member of the IOF board, made the comment, Brazilian researchers and health professionals are working to find answers to the problems of osteoporosis and related musculoskeletal diseases. So very important problem in both countries. If we look at the healthcare costs in the United States currently, I have some old data there, it's almost $30 billion with a B. And for us, our hip fractures cost about $40,000 while they're in the hospital. And that's a lot of money, but actually about 70 to 90% of what's spent on our hip fracture patients are after they get discharged to the hospital. It's to the nursing homes, it's to the hospice care places, which cost a significant amount more. When we look at cumulatively, they're estimating this is going to be $500 billion. If we look at it in Brazil, hip fractures and fragility fractures have a 13% increased length of stay compared to someone else, averaging 11 days for a hip fracture in Brazil for a hip fracture. Inpatient costs continue to grow, and in Brazil, the cost in US dollars is about $4,000 to $12,000 for a hip fracture, and that's just the inpatient cost. So again, huge numbers, and if you look at congestive heart failure and asthma, both of which are very common in the United States, they don't touch the amount of money we spend compared to osteoporosis. And the majority of that, as you saw, is really based in our hip fracture patients. In addition to what we talked about, the cost while they're in the hospital, there's a huge burden of the disease. And so it's the quality of life, it's the patients that no longer go to work, it's the patients that fill up our nursing homes. This is an enormous cost that's very hard to categorize. It's also a problem in men. So oftentimes we feel like men aren't going to have the problem in osteoporosis and fractures, but as I said, 1 in 4 are going to have this problem. And in the United States, close to 2 million American men have osteoporosis, so definitely an issue. So the question is, as orthopedic surgeons, what do we need to do? Well, these fractures, like a hip fracture, I think are sentinel events. And these sentinel events should tell us that there's something else going on with the patient and not just the fracture. The problem is we're typically not addressing it. These are some numbers in the United States and Brazil, and patients that have these fragility fractures are very rarely being addressed with osteoporotic medications or appropriate referrals to have that part of their bone disease treated. It's definitely a community issue. You need to get primary care physicians on board. You need to have an entire network to really want to manage this. If you do it well, treatment works. And I always hear from orthopedic surgeons, well, we fix fractures, we don't prevent them. But there's more and more fractures happening, and by preventing them, you're going to save your hospital systems, your country money. You're still going to have more than enough fractures to take care of. So when we look at this, I mean, we all see a fracture, but what we probably should be seeing is something different. And I'm just going to play this little video clip to show the sort of stereotypes that we have in orthopedics.
I need to fix it.
Can you tell me more?
The fracture is very displaced. I need to fix it.
Okay. Let's start from the basics. Where is the fracture?
The fracture is in the emergency department. I need to fix it.
That's not what I meant. Who does the fracture belong to?
The fracture belongs to a bone. The bone is a femur.
And who does a femur belong to?
The femur belongs to a 97-year-old lady from a nursing home.
Okay. Anything else you can tell me?
She is fasted. That is good.
Any comorbidities?
She is otherwise well. Except for
what?
Her temperature is 29 degrees.
Right.
And her pH is 6.8.
Really?
And she has a condition I have not seen before.
Which condition is that?
A systole.
So clearly we get stereotyped all the time, and I just use that to illustrate that we should be seeing more than just a fracture, but we should really be seeing the patient and think about the underlying problem and be prepared to treat the underlying disease. So if we look at some of the opinions of orthopedic surgeons in a survey that was done, most of us recognize that it is a problem and we should be doing something about it. However, when we talk about orthopedic surgeons prescribing any kind of medicine, all of a sudden we get a little uneasy and maybe not so familiar with what that is. And half suggest that we should probably still do this, and other half say no. I think in reality that we really need to address this. It doesn't always have to be with medications, but it has to be with recognition. So this is a typical cycle. We see a fracture. patients get a surgery and they come back with a second fracture. And what we're trying to do is intervene at some point. And for us in the US, we usually have a bone health service now that we've been trying to develop. And it usually involves primary care physicians. It may involve our nurse practitioners, our physical PAs, all of which help try to break that cycle. And ultimately, you need to have someone at your institution that really takes this to heart and is willing to push forward to recognize this is a problem and make a difference. These are the typical 10 measures that I think most of us find important when we're dealing with patients with poor bone. A lot of which we can have done by our ancillary staff: nutrition counseling, physical activity, lifestyle counseling, all very easy. Most of those are done by our PAs, our nurse practitioners, and our nurses. It's a little more difficult when we think about pharmacology and testing and communication to make sure that our patients are getting the osteoporosis looked at. So for us as orthopedic surgeons, even if you don't want to use bisphosphonates and you don't want to use some of the other medicines that are out there for osteoporosis, I will tell you something that's very easy to do. Put your patients on calcium. They should get 1,000 to 2,000 milligrams a day, usually in 2 doses. They need to be on vitamin D, 2,000 international units a day. Both very easy, very simple to do. May not elect to manage osteoporosis beyond that, but I do think we're all inclined to make sure that they do get an appropriate referral to someone who can manage it and treat these problems. There are benefits for us in doing this. In the United States, we're starting to see some regulations come out. There are PQRS measures so that we can meet if we actually demonstrate that we're communicating when we have a patient with a fragility fracture to a bone health program. There's some concern for liability. So you treat a hip fracture, but you don't address the underlying problem and they break their hip again. There's concern that maybe we'll actually be sued because we didn't treat the underlying problem. And then we also see, since starting our program, a huge positive return on investment in that we're getting more and more referrals from families, from physicians to our bone health program to manage these problems. But in general, I think it's really, and most importantly, about caring for your patients in your community to make it better and make it safer. Thank you.